I'm Andrew Hearn. I am a vascular surgeon from Cincinnati, Ohio, and I'm very privileged to be able to present antiplatelet therapy in cardiovascular disease as part of the NCVH meeting online. I have no conflicts of interest to disclose. So my talk on antiplatelet therapy is very important because peripheral artery disease and cardiovascular disease are disease states. It doesn't just affect one part of the body, but it involves the whole condition. So if a patient has claudication or if they have angina, then it affects their whole body, and it is an indicator of longevity and mortality. So we don't just treat the symptoms of the patient, as in claudication, but we want to decrease the secondary effects of stroke and heart attack and death related to peripheral artery disease and cardiovascular disease. As a vascular surgeon, I'm going to focus more on antiplatelet therapy in relation to peripheral artery disease. So peripheral artery disease presents in various forms. Half the time, patients are asymptomatic, and you might find decreased pulses or calcification on x-rays of their lower extremities, and this is true in 50% of patients. Other symptoms that manifest with peripheral artery disease are claudication, ischemic rest pain, and ulceration or gangrene. These patients have either asymptomatic peripheral artery disease or symptomatic peripheral artery disease. They need to be treated for secondary complications such as stroke or cardiovascular events such as MI and vascular death. So all patients with peripheral artery disease therefore benefit from antiplatelet therapy because it decreases secondary complications. As a vascular surgeon, we're graded by the hospital on the percentage of patients who are on antiplatelet therapy. In the past, we always relied on the family physicians or the primary doctors to treat their medicines of either the statins or antiplatelets. Now we are monitored by our hospital system on the percentage of patients, and our goal is 100% of the patients will be on antiplatelet therapy. Now, if they are on anticoagulant or have contraindications to antiplatelet therapy, then we have to list that in their chart to state why we don't have them on antiplatelet therapy. Otherwise, any patient with peripheral artery disease should be on antiplatelet therapy because the mortality of peripheral artery disease is so high. So the antiplatelet agents I want to talk about are in three categories. 1, aspirin, 2, Celostazol, and 3 would be the P2Y2 inhibitors. So let's first talk about aspirin. Aspirin works by decreasing the platelet adherence, therefore thinning the blood by decreasing platelet aggregation. It is given a class 1 recommendation for the management of symptomatic peripheral arterial disease. That further reinforces the fact that all patients with peripheral artery disease should be on aspirin unless there is a contraindication. And if the patient has a contraindication, that contraindication needs to be listed clearly in the patient's chart. Aspirin is effective in peripheral artery disease, not so much by affecting the symptoms of peripheral artery disease, but it reduces the secondary complications by reducing MI, stroke, and cardiovascular death. Celostazol was approved by the FDA for the treatment of claudication in early 2000. It's the only other FDA-approved medication besides pentoxiflin or Trentol. Celostazol in studies have shown that is it is effective in increasing walking in patients with claudication. It is not effective, however, in 100% of patients. Studies have shown that approximately 1/3 of patients with claudication will benefit from a further walking distance. 1/3 of patients will remain about the same, and 1/3 of patients will continue to worsen. So it's really the only treatment that we can give for claudication. How does Celostazol work? We're not really sure of the true mechanism, but chemically it is a phosphodiesterase inhibitor with a mild antiplatelet effect. Phosphodiesterase inhibitor increases intracellular calcium. It works somewhat almost like in the caffeine family by stimulating heart rate. So patients with a history of congestive heart failure are contraindicated to have Celostazol because of increasing the heart rate and the cardiac demand. It is a class 1A recommendation to improve symptoms with claudication. So patients with claudication should benefit from an initial trial with Celostazol. And this is true for interventionalists who treat patients with claudication. They should first be managed conservatively with antiplatelet therapy, aspirin, and Celostazol. And if their symptoms worsen despite conservative therapy after 3 to 6 months, then they can be considered for either endovascular or a surgical approach. The P2Y12 inhibitors include ticlopidine and clopidogrel, and they are both indicated for use in peripheral artery disease. They are effective in coronary artery disease and are required in patients who have recent stents in their coronary arteries. As far as the peripheral artery disease, if a patient has a stent placed, it is not necessarily indicated. The way I treat patients is to give them a 6-week course of clopidogrel. They work by inhibiting platelet receptors, thus thinning the blood. Clopidogrel is the agent that is used the vast majority of time. Ticlopidine has a higher incidence of hematologic side effects. Clopidogrel data is supportive of using as a monotherapy in peripheral artery disease. There have been head-to-head studies with clopidogrel versus aspirin, and there has been a slight increased benefit shown for patients on clopidogrel. For the most part, in my practice, I put patients on aspirin if they have peripheral artery disease. If they have continued complications or worsening of peripheral artery disease, then we will add clopidogrel as additional benefit. The clopidogrel is effective in decreasing patients with peripheral artery disease, MI, stroke, and cardiovascular death. It is a class 1 recommendation as far as an antiplatelet agent in the use of peripheral artery disease. In my opinion, if a patient has peripheral artery disease, they should be on either aspirin or clopidogrel, unless there is a bleeding contraindication or if they're already on anticoagulants such as warfarin. There's always a question on whether patients will benefit from dual antiplatelet therapy. So if peripheral artery disease is such a deadly disease, do all patients benefit from aspirin plus clopidogrel? Well, the studies have not been conclusive. In my practice, patients will be on both an aspirin or Plavix if they've had recurrent symptomatic disease. In other words, if a patient has come in for a bypass or a femoral stent and reoccludes the bypass or the stent, then we will add dual antiplatelet therapy. It is not an initial therapy that we give. The side effect of dual antiplatelet therapy, of course, is increased bleeding risk, which can outweigh the benefit of reduction of cardiovascular events. There is data to support a low-dose aspirin with clopidogrel or anticoagulants. Recently, in the last 1 or 2 years, with the new anticoagulants, the NOACs, and a low-dose aspirin, there has been significant decrease in cardiovascular events. There further studies are to follow, but the COMPASS trial reported in the New England Journal of Medicine in 2017 showed beneficial effects on using low-dose aspirin with the newer NOACs. In conclusion, peripheral artery disease is a deadly systemic disease. The 5-year mortality of peripheral artery disease is in the 25 to 30% range, which mirrors that of some of the deadly cancers that are out there. If in this picture, if you take critical limb ischemia, the most advanced portion of peripheral artery disease, the 5-year mortality is estimated to be 75%. Now, we can treat these patients with bypass and advanced endovascular procedures and save their limbs, but they're still at risk for cardiovascular events in the future because peripheral artery disease is a marker. They're at risk for MI, stroke, and cardiovascular death. So to increase their risk, even when we have successfully treated the blood flow problems to their limb, antiplatelet therapy is a critical portion of their treatment regimen. And that's the main take-home point from this talk, is that peripheral artery disease is a major risk for these patients, and to lessen their risk, something as simple as a daily aspirin will benefit these patients. So the bottom line is that patients with peripheral artery disease benefit from antiplatelet therapy unless contraindicated. Aspirin alone or clopidogrel alone are class 1 recommendations. That means it's backed by prospective randomized trials. For more severe peripheral artery disease, consider combination therapy, which would be either dual antiplatelet therapy or adding a low-dose aspirin to anticoagulants. Thank you for the privilege of being able to present for this meeting.